Thank you. So we have our next presenter, Dr. Nishikant Borse. So Dr. Nishikant Borse is a very prolific and experienced VR surgeon. He's practicing in Mumbai itself. And over to you, Dr. Nishikant.
Yeah, thank you, Sangeet. I should thank Sangeet for including me in this IC. And thank you, AIOC. And my topic today is vitrectomy in retinal vasculitis. And as compared to the wonderful cases that you've seen, this comes back to the basics and the very common things that we see. And the question comes in as why would we do vitrectomy in vasculitis? And the most commonest cause is a non-resolving vitreous hemorrhage that we have seen in cases with vitritis which goes on for a much longer time. Of course, tractional retinal detachment, combined retinal detachment, epiretinal membrane, and retinal folds are the other indications for which you might be doing vitrectomy in case of retinal vasculitis. Okay, now vitreous hemorrhage, like I said, it's the most common indication, and of course we have to do a B scan in these cases to see what's the status of the retina. And we have to give adequate time for the medical treatment to work. We cannot rush into it because many a times they do clear off if the inflammation does settle down well. Now, always when you take up a vitrectomy, please give a guarded prognosis, because with the vasculitic element, we really don't know whether the macular area is involved or how it is, and hence we have to be extremely careful when we do vitrectomy. Now, this is the case where vitrectomy has already been done. Most of the core vitreous hemorrhage is gone, but it's on a fast forward mode. But what I would like to drive in is that it's very difficult to induce a PVD in these cases, especially, especially if, you know, how do I go back? Yeah. So especially if there is a NVE, which is down here, and if you have a temporal scarred area where the PVD just cannot be induced. So you can see in this case, the nasal side or over the disc, the PVD can be easily induced and the vitreous can be dissected. But as you go to the periphery, you will find that it becomes tougher and tougher, and the vitreous is just too adherent out there. And as you start dissecting, you can see there's a band of vitreous which is so adherent here that you really cannot dissect it beyond a particular point. And I think it is best that we don't try too much, otherwise you'll end up causing retinal tears and you can lose the eye. So it is best to dissect around the vitreous and leave that particular vitreous trimmed and attached as much as you can, if possible. Now, this is a typical scenario that you will get in vasculitis with peripheral NVEs and the vitreous very firmly attached. And the best thing that you can do is just induce the PVD up to the point that you can go, and then trim it as much as you can and go as close to the retina as possible. And now with the 25 and the 27 gauge cutters coming in, we can really go extremely close to the retina, and we can be sure that we are not left a lot of retina there. It is always okay to leave some amount of vitreous sticking there rather than causing a rhecoma in an area where the retina is already having attraction. Secondly, many a times I would prefer to do an ILM peeling in such cases, because we don't want a post-operative epiretinal membrane come in there because of inflammation that happens. Now, this is the same case. You can see post-operatively doing very well, and you can see that the area where the vitreous was very adherent, that is also stable, and the laser marks have taken care of the area there. So that's the tip that you need to do when you're doing vasculitis. And of course, as Saurabh had said, it is always worth doing an encerclage in such cases. Now, when you come to the tractional RD, we have to understand that there is a fundamental difference between the tractional RDs that you see in cases of retinal vasculitis as compared to diabetics. In diabetics, it is most of the time posterior, it is around the arcades, whereas in case of TRDs due to vasculitis, it is many a times it is peripheral. And these patients are younger as compared to diabetics, so they have a phakic status. So again, that makes it difficult for you to dissect in the periphery without really causing any lens changes. So again, like we discussed earlier, an encerclage does come into handy in such cases. And ARM is very common due to inflammation, so we have to be more careful. Another thing is the quadrants can be more than one, and we have to really search for them and take care of any place where we find the tractional to be there. Now, many a times the tractional RD is just in form of a fixed fold which can sort of extend from the disc to the periphery of the area where there is vasculitis. Again, like I said, it is extremely difficult to do a complete vitreous dissection, especially in the periphery, and the vitreous is really very adherent to that. Now, many a times you would cause a retinal hole or a tear in such cases when you're doing the dissection, but if you do that, make sure that there is no residual vitreous band that is connecting your regma to or the particular place. Otherwise the traction is just going to cause a recurrent retinal detachment. Now in this case we have managed to do the dissection around the disc perfectly well, but if you see, as we are doing the dissection in the periphery, there is a regma that occurs, and now the regma has to be totally disconnected with the vitreous, and only when you totally disconnect that particular regma from the vitreous, you can be assured that this patient is going to do well. And this is the post-operative picture of this patient. Many times you do get combined RD, and the tears can be in the equatorial area. And another tip is, when you're doing a fluid gas exchange in such cases, you may not get just a simple viscous SRF that you see in TRD, or you can not get just a normal aqueous one. It's generally a mix of both. But the tip is that you have to do an extensive laser by searching all the areas of vasculitis and ischemia that you can see, especially with the sclerosed blood vessels. And you have to go ahead and cover up the whole retina. So if you see the post-operative picture on the lower left side, you can see that extensive lasering and treatment has been done in the periphery to the area of vasculitis. Otherwise, you can get recurrent hemorrhages and complications. Coming to the last video, this is a typical scenario that you get many a times in an unfortunate case where it is a chronic vasculitis, and you can see the disc is really pale, and you are just going to do for whatever visual benefit that you can get for this patient. Now again, dissection of the vitreous is extremely difficult, so you have to be very patient. You can't just use the cutter. You have to use a combination of forceps and cutter to slowly remove the vitreous phase from the retina. It is very adherent in the areas of neovascularization and in the area where the vessels have been inflamed. It's a very thick hyaloid, so you have to go patiently, step by step, piece by piece, and go on dissecting it till the time you can go to the end. And this is the end result that you can get. You can see the blood vessels are sclerosed, and look at the macula, it's quite fired off. And that's why, again, any case that you're dealing with vasculitis and vitrectomy, be sure that you're given a guarded visual prognosis, because we really don't know the macular status when we open up in a case. So in conclusion, I would say that the tractional retinal detachments and the combined retinal detachment in vasculitis are complex and make the surgical management very challenging in these cases. Okay, and as you see, the retinal vasculitis TRD is very different from diabetic cases, so you have to be very careful while doing the treatment for this. Vasculitis TRD is often complicated by combined RD, peripheral fibrovascular polyps, retinal folds, and iatrogenic retinal breaks do occur. So we have to be very careful with the vitreous dissection. Majority of the eyes, however, have a good anatomical and functional outcome if you do a proper pars plana vitrectomy. And then additional anatomical variations in vasculitic eyes like TRDs when compared to diabetic TRDs, that's what I highlighted in the photograph that I had seen in the section before. Thank you very much. I would again like to thank Sangeet. There are a few videos which Sangeet has donated for this particular talk. Thank you. Thanks a lot for patient listening.